Hi, everybody. So this is the third one that we're going to talk about. So we're going to talk about rate disturbances, and rate and rhythm go hand in hand. So we're going to kind of cover both of those again. Sorry, what I mean is we'll cover rhythm again. So even if you didn't catch up to everything before, you should hopefully catch up to everything now. Um, so let's get on to it. So we're talking about disturbances of rates. Let me just get my laser pointer up over there for you guys so that we can get going. All right. So the first thing is, what is normal? So a normal adult heart rate is between 60 to 80 beats per minute in a resting adult, all right? You can sometimes get well-conditioned athletes, people who are very active, they have resting heart rates that are below this. And well, there's many ways actually to determine heart rate on an ECG. The most common way now is just to look at the top of the ECG. So in the old days, I'm kind of giving away how old I am. We actually didn't have machines that gave us the rate. We had to work it out ourselves. So this what I'm teaching you now is just for interest's sake. But basically, the time it takes the machine to move from one thick line to the next thick line is 0.2 seconds. And the time it takes to move between the thin lines is 0.04 seconds. Okay. So that's how you work out timing on your ECG. And it depends on your settings as well. But if you have your standard settings, that's how it works. So the way that we used to work it out before was count the number of blocks between the R waves. So in this case, it would have been 1, 2, 3, 4. We would then take 300 divided by 4, and you get about 75. And then if you became very technical, you would go by 3.8 or 3.7, things like that. And then you would work it out from there. If you're very clever, you could remember the sequence, then you could learn that off. But nowadays, like I say, all you need to do is just look at the top of your ECG. Most machines, when I say most machines, all your machines print it out for you. But not to worry, I'll be working out your rates on this one, so you don't really have to remember that. Okay. So remember, you still need to check your axis, you still need to check your rhythm, and sorry, just a little joke. And then you come to your rate. And the rate and rhythm are interchangeable. You can work out either one first. Okay. So what we're going to do is we're going to try some, and we're going to hopefully learn some diagnoses as well. So let's have a look at this one. So let's start with the rate first. So let's just pick an R wave here. Okay, so we've got 1, 2, just above 3. So this heart rate is about 107, maybe 108 beats per minute. So we've got a tachycardia. Okay, now let's look at our rhythm. So if you remember, you can, if you guys want to challenge yourself again, you can pause the video and work on the rhythm yourself and then restart again. Up to you. I'll give you a second. Okay, but we've got a normal P wave, all right, and we can see that most of the P waves are quite normal. Our PR interval is 1, 2, 3.5 blocks, so it's in normal. We've got narrow QRS complexes, all right, and we've got a QRS following every P. Okay, so we've got a tachycardia with a sinus rhythm. So when we put this a tachycardia with a sinus rhythm, what you get is a sinus tachycardia. Now, a sinus tachycardia this is correct. I'm not going to get you guys too worried about it, but sometimes you may see sinus tachycardia being demonstrated, even though QRS complexes are missing. That's something completely different. For now, we're just concentrating on basics, all right? So I don't want you to get confused, or if you've seen something in another book, just don't worry about that for now. Okay, so let's go to another one. So let's start first with the rate. So the rate now, I'll work it out for you. It's about 1, 2, 3, 4, 5, 6, 7, 8, 9. So 300 divided by 9, you've got just over 30 beats per minute. So it's a bradycardia. Let's look at our P waves to determine our rhythm. And again, if you want to challenge yourself, you can have a bit of a pause now. Okay. So we can see that we've got these normal looking P waves, relatively normal looking P waves. Okay. Let me just hide this. I think that might be a bit better for you guys. Okay. It's just no, it's not going to keep that there. All right. So, right. So you've got these normal P waves. Let's look at our PR interval. Got 1, 2, 3, it's borderline, but it's within normal, maybe just either one side. But anyway, let's not get too heavy into it. So we've got our, whatchamacallit, normal PR interval, narrow QRS complexes. Our QRSs do follow every P, and the patches are quite regular. So we've got a, what type of bradycardia would you say? That's correct, sinus bradycardia, because it's a normal rhythm, but with a bradycardia. Okay, so this is how we get to those terms. Now let's try another one. Right, so everybody gets a bit scared when they see this, but let's have a look and see. So first, let's work out the rate. So the rate is about 1, 2, so just above 150. So we've got quite a heavy tachycardia going on here. Let's look for P waves. So the first thing we notice is that we can't see any P waves. So we can't talk about a PR interval. We can't talk about a QRS after every P. We can't talk about PR. Yeah, so we can't talk about any of those things. But what can we talk about? So let's look. First of all, our QRS complexes are narrow. All right. This is your ST segment. Remember that. That's not actually your QRS complex. So your QRS complex is that. Your QRS complex is narrow. And are they regular? Yes, they are extremely regular and they're quite thin. All right. So do you think you can make a diagnosis on this one? We've got a tachycardia that is coming from above the ventricle. Why do we say above the ventricle? Because we've got a narrow QRS complex. So if we had a wide QRS complex, it would be coming from the ventricle. But because we've got a narrow QRS complex, we have a tachycardia that's coming from above the ventricle. So this is a supraventricular tachycardia. And this is quite typical of supraventricular tachycardias. And you're going to see a lot of these if you work in emergency departments. So supraventricular tachycardias, let's look at our criteria. They don't have P waves. They have narrow QRS complexes, but they are extremely regular. You'll notice it doesn't change. It doesn't move not one little bit. It stays exactly the same. So that's why we call it a supraventricular tachycardia. Okay, let's just skip that one. Let's try this one. So this is also a tachycardia. It's now also about 150 beats per minute. Let's look at our rhythm. Can we see P waves? Can't see any P waves as well. We can't talk about a PR interval. We can't talk about a QRS after every P. But what do we notice about our QRS complexes? They're extremely wide. All right. All right. And they are relatively regular. Okay. So we said that narrow complex without P waves is a supraventricular tachycardia. And a wide QRS complex, can anybody guess? Yes, if you guess ventricular tachycardia, you are 100% correct. Okay. This is exactly what a ventricular tachycardia looks like. Okay. So very good. Let's go. So that's a ventricular tachycardia. So as a general rule, right? It's not an overarching rule. Thin complexes mean the electrical activity originates in the atrium. All right. Thick complexes imply the stimulus or pacemaker is the AV node or lower. So as you go down to the bundles and the Purkinje fibers and all of that, you're actually going to get lower and lower heart rates. So that tells you about ischemia and damage that's taken place, even direct damage and things like that. Thin complexes, remember, generally the electrical activity is originating in the atrium, generally. Okay, right. Let's try one now. So this is also a bradycardia. Let's have a look and see. The rate is quite low. So the rate is about 1, 2, 3, 4, 5, 7, 8, 300 divided by 8. So we're coming close to about 48, 50 beats per minute. So it's quite a slow brady that we've got. Let's look at our P waves. So we have P waves. They're normal P waves. They're quite regular P waves. There you can see there's one that's hidden in the QRS complex and then it comes out again there. Can we talk about a PR interval? Not really, because a PR interval is all over the place. It's not regular at all. Our QRS complexes are wide, all right? So that means this ventricle is not getting any stimulation from the atrium, all right? Or very little stimulation. Let's say no stimulation for now. And are the groupings regular? That's a bit of a, well, let's have a look at it this way. The atrial groupings are regular. The atrium is functioning at about 100 beats per minute, right? There's about 1, 2, 3 blocks between each one, and that's quite regular. And the ventricles are functioning as well, quite regularly at about 50 beats per minute. So what you have is an atrium that's functioning on its own and a ventricle that's functioning on its own. And if you remember back to when we talked about rhythm, that means that you've got a heart block and it's a complete heart block. Why do we say complete? Because there's no association between the atrium and the ventricle. Okay. And remember, third degree heart block, quite a serious condition, and it needs to be seen by a physician, cardiologist. These patients often need a high care unit. They need to have pacing done. There's often a lot that goes wrong with them. But if you don't pick it up in the first place, you're not going to save your patient. Okay. Right. So third degree heart block. So there's no connection between the P waves and QRS complexes. P waves are occurring at a regular rate, as are the QRS complexes, but they are occurring independently of one another. Let's try another one. So this is also a tachycardia of just under 150. And what's the first thing you notice about these P waves? These don't look normal. We don't normally have P waves that look like this. P waves are not normally so sharp. They're not normally so angled and things like that. So there's something going on over here. What's our PR interval? 1, 2, 3. So it's actually relatively normal there. QRS complexes are narrow and our QRSs are following every P and the groups are happening quite regularly. So if you were to call this a sinus tachy, nobody would argue with you. The only thing that would be lingering in your mind is what's going on? Why does this look like that? Now, this is a difficult one, I must be honest. This is actually an atrial flutter. But I'm going to show you now what is more typical of an atrial flutter. So what happens is an atrial flutter looks like this, what we call a sawtooth pattern. So if you've ever seen a saw that's used to cut wood, this is what the teeth look like. So this is a sawtooth pattern, all right? So what happens in atrial flutter is that you have this atrium that's going extremely fast. So in this case, it's beating at 300 beats per minute because there's only one block between each atrial beat. And from there, 1, 2, 3, 4, 4 atrial beats and a ventricle gets a beat. 1, 2, 3, 4, and a ventricle gets a beat. So this is called a 4-to-1 atrial flutter. So you could have, for example, if that wasn't there, you would have 3-to-1, 2-to-1. You could even have 5-to-1, 6-to-1, depending on what happens. So atrial flutters have the sawtooth pattern. And please remember that because atrial flutter is actually quite common. And you will see patients with this from time to time. All right. You'll notice the absence of the T waves, though. They don't have T waves. Okay. So I know that was a bit of a difficult one, but just to show you that if something doesn't look right, don't just leave it and walk away. Ask. Okay. So let's try another tachycardia. So why do we say it's a tachycardia? Because it's so irregular. How can you call it tachycardia? Tachycardia is based on the two narrowest QRS complexes. So at its highest, the heart is going at about 150 beats per minute, maybe even a little bit more if you look at that. So if you look at this one, we don't have P waves. All right. So we've got no P waves. So no PR interval, no QRS after every P. And we've got narrow QRS complexes. But one thing you'll notice is that they are absolutely irregular. There's no regularity about them. Okay. Now, we saw this in our last one as well when we talked about rhythm. This is atrial fibrillation. So your atrium is just fibrillating along over there. And every so as it fibrillates, it sends through signals. So your ventricle is still seeing something coming from the SA node, just that it's getting it very irregularly. Okay. Now, what we're going to do is I want to compare these two just to show you how important it is to know the differences. So at the bottom, we have an SVT, supraventricular tachycardia, and at the top, we have an atrial fibrillation. So let's look at the similarities. Both of them don't have P waves, and both of them have narrow QRS complexes. But what's the biggest difference? Atrial fibrillation is absolutely irregular, and supraventricular tachycardia is absolutely irregular. Why is it important to know this? Because of how you're going to treat these patients. The way that you treat atrial fibrillation is completely different to the way that you treat a supraventricular tachycardia. So just to make it a bit easy to understand what I'm trying to say, we normally, for atrial fibrillation, give anticoagulants, things that will prevent clotting, all right? And for supraventricular tachycardias, we try and bring the rate down. So that's with chemicals or by cardioversion with the defibrillator, things like that, all right? So I want you to imagine that you mix up the two and you call this an atrial fibrillation and you give this patient a anticoagulant. You might as well have given them Smarties because you'll have helped them just as much. More worrying, atrial fibrillation, because the atrium is just fibrillating along over there. When you leave blood in a container, for example, and you just start shaking the container, the blood starts to clot. So that's what happens in this atrium. You start getting blood clots forming. So you need to anticoagulate the patient here. So if you bring this patient's heart rate down to normal and you actually get their atrium functioning again, for example, they're going to start shooting off clots. Now, I'm just talking in general, we're not getting into specifics. There's a lot of variations of this. So it just shows you the importance of making sure that you go through these and learn the different criteria as you're going through and as you're learning. You have the tools now, so you know how to differentiate them. Okay. So remember, atrial fibrillation, no P waves, narrow QRS complexes, absolutely irregular. This is a very nice one because you can see the fibrillation. On some machines, you can't see this. It actually looks just like a flat line. So you have to look for other criteria. Okay, got it. Excellent. Right, one final one. So when I used to present this in the unit, I used to always tell everybody doctor of the week. But in any case, that doesn't apply now. So challenge yourself. I'm going to give you a minute, pause, and go through and see what you think. Okay, now I'm going to start talking. So the first thing that we notice is that there's no P waves. All right. So there's no P waves. And we can't talk about a PR interval. We can't talk about a QRS after every P. But we've got narrow QRS complexes. Narrow, absolutely narrow QRS complexes. And to top it off, they are regular. So this is not an atrial fibrillation, that's for sure. And what is our rate? We've got, let's take it from here, 1, 2, 3, 4. So the rate is 75. So it's not even a tachycardia. So it's not a supraventricular tachycardia, which would fit into that pattern. We said a supraventricular tachycardia has no P waves, has narrow QRS complexes, and is regular. But this is not a tachycardia, so it can't be a supraventricular tachycardia. So what is this? That means I've taught you nothing, eh? No, I'm just kidding. The reason why I put this one here is because I just wanted to show you guys that even if you don't know the diagnosis, you need to be able to pick up the abnormalities. Now, this patient has something called a junctional rhythm, all right, or an accelerated junctional rhythm. And even accelerated junctional rhythms, there's a few of them. You get junctional bradys, junctional tachys, junctional extreme. There's so many. The important thing is that even if you don't know the diagnosis, you need to be able to pick up the abnormalities. Now, in this case, why it's called a junctional rhythm is because between the atrium and the ventricle, you sometimes have extra pacemaker cells that sit in that junction, the AV junction, and they take over the work of the SA node. And that's why the AV node still is getting its impulse from higher up. So it still gives you a narrow QRS complex, but it just shows you how complex it can be. That's why when you visit a cardiologist, they charge you 3,500 rand cash because they've had to learn all of the stuff over years. It's not easy. And your job when you first start as an intern or as a comm-serve or as a student is not to be able to make every diagnosis, but to be able to pick out abnormalities. And when you can pick out an abnormality, then you can go ahead and tell somebody who can then escalate it or figure it out themselves and then manage the patient. Okay. But normally, if you were to see this, imagine a patient coming in with severe chest pain, and you look at this and say, but this looks absolutely normal until you realize, but this atrium is not functioning. Why is this atrium not functioning? What's happened, So that's why it's so important to know. So I hope it will prompt you to go and learn more about rate abnormalities. And then once you are comfortable with all of them, then you can learn about treatment. Okay. So this is just a joke to finish off. But again, if you guys have any questions or anything that you'd like to know, you can message me and we'll try and take it from there. So the next one that we're going to cover is actually the zones of the heart. So I'm hoping that we'll cover that, and then you'll understand what each part of the heart is being looked at by the different leads. Okay, okay, guys. Thank you very much, and yeah, see you for the next one.